The Michigan Opioid Prescribing Engagement Network, Michigan O.P.E.N, is an effort that's trying to take a novel approach to the opioid epidemic by focusing on surgery and dentistry and some work in emergency medicine, and in particular, focusing on people not using opioids before their care who are going to undergo these predictable exposures, and thinking about pathways for these patients to try to decrease the long-term poor health outcomes that can come from that opioid exposure, and also thinking about the patients and their families and how to ensure that we're creating safer communities. Our group is definitely multidisciplinary. We have 3 co-directors. I'm an anesthesiologist pain physician. My other 2 co-directors are both surgeons. One's a plastic surgeon, hand surgeon, and she's a health services researcher. And then our other co-director is a transplant surgeon, also directs medical education for a medical school. We have statisticians, other pain physicians. We have other types of surgeons, addictionologists, research assistants, implementation specialists, nurses, pharmacists. We've got a big team trying to tackle a very complex problem. So we actually have a really unique relationship with insurance companies in the state of Michigan. Blue Cross Blue Shield of Michigan has been very forward-thinking. They fund a network of collaboratives that basically cover every major hospital in the state of Michigan, physically coming together mainly around surgeries, mainly around surgical quality from around the state, and have really made Michigan one of the safest places to have surgery when we think about traditional surgical complications. And we went to Michigan Department of Health and Human Services more than 2 years ago and asked for the opportunity to use this platform to superimpose an opioid narrative, to get real-world prescribing and real-world consumption data from beyond the ivory tower, from beyond just an academic medical center, and really understand what was happening in our communities as it related to surgical care, pain care, and opioids, and to create patient-centered recommendations and evidence-based recommendations that are more than just expert opinion, but even more importantly, as a platform through which we could disseminate that information and avoid that 7 to 10 year lag that goes from discovery to implementation of an important finding. Well, we're excited. We actually do have another state that's joined in. Delaware has actually started down this pathway, and so we have Delaware open, and we have other states that are interested. And to be clear, while we may not have other states that are taking the O.P.E.N name, we've shared with other states, Illinois, South Carolina. We've got some great partners out there with other surgical collaboratives that are doing similar work. A big part of how we disseminate our information is conferences like PAINWeek, but also smaller, more grassroots efforts. We go out and talk to a number of physician groups, and now we're trying to expand into nursing and social work and really broadening our footprint to help try and disseminate the information. We think some of this will happen through insurance companies, just understanding what we do, and hopefully broader understanding from the Medicaid, Medicare community. I think these are all opportunities. So our group has tried to initially focus on common surgeries. We want to have impact, and we've initially focused on people not using opioids before surgery, which seems odd. It maybe seems not necessarily how most people would start. Most people would feel the challenges of the preoperative opioid user and immediately say that's where we need to start. What our group has shown, an important contribution, is that between 6 and 13% of patients not using opioids in the year prior to surgery go on to become new persistent users or new chronic users. And put another way, we could actually say that this is by far and above the most common complication of surgery, and yet something that surgeons don't talk to their patients about. So this is an unmet opportunity. Beyond that, we know that excess prescribing after surgery is common, with about 70 or 80% of the pills we prescribe to patients not using opioids going unused, but unfortunately not being safely disposed of. And so our group is working on right-sizing prescribing to not only focus on the patient, but their kids and their communities, and also we have an important pillar where we do opioid drives around our state, that we coach up sites to do opioid drives. Our last one was 27 cities. We had over a ton of pills returned. The most common reason for people to have excess pills is from surgery. In fact, if we add in dentistry, it's about 3/4 of the people that attend our drive have excess pills from surgery or dentistry. So we know we're in the right space, and we know that in the post-CDC guideline era, the impact of surgery and dentistry, especially as we relate to new starts and new exposures, is only becoming more important, and we anticipate that that importance will continue to grow for the coming years.